I've done that. It was in one of my, it was something that we did in PD. They were demonstrating a new drone that could actually run into, it could actually slam it into cytoconics containers, things like that. It was designed to go interior, and it was really robust. So it wouldn't actually do damage, but carbon fiber cages all around the blades. Wow. It actually had a spinning carbide tip that was designed to break windows. It was kind of, it was patterned after the, they were thinking about the Vegas shooting, and a kid made a startup company and basically has a spinning carbide. You could fly up to a window, bust a window, and you would have access to the shooter or whatever like that. So it was kind of interesting, so, to say the least, but yeah, always fun stuff. Thank you for being here. This class has to be recorded, so remember that. So it's going to go across the state to some evaluators and see how we did. You guys know me, I'm Rob McQueen, I'm a paramedic. We're going to talk about first aid provider, basically fire-based stuff. This is one of the basic essentials classes that is for firefighter 1 and 2. So I believe everybody in here is a little beyond, because they talk about kind of first responder and things like that in here, but we're gonna discuss communicable diseases. We're gonna discuss some PPE stuff, discuss bleeding, some shock, some CPR. There are some practical evaluations at the end. We're gonna actually do 2 minutes of CPR, hooking up the AED and make it function, and we've got to hook up a non-rebreather that's required by the class. So there is a short little test that you'll take in here, and we'll get that accomplished. So this class is supposed to take about 2 hours by requirement, so we'll get it done. You guys are last out, so if you hear tones, we'll just listen, and if it's something big, we'll figure it out, we'll adjust and restart the class later, I suppose. So first aid provider, out of the essentials manual. Everything has to have learning objectives. Everything we do in fire service, we have objectives of why we're doing the class. So describe the role of fire and of the fire service in providing emergency medical care. Basically, guys, we're treatment on scene, we transport. All right, that's basically what we're supposed to do. We're ER mobile. We try to get things established. We try to buy the person time to be able to get them to the hospital. All right, simple as that. Types of ambulance services: fire-based, hospital-based, third-party EMS services. Anybody here worked in a hospital base ever? Okay. You guys familiar with that? Basically, they're functioning in the ER, and then there's an ambulance call, they leave the ER and they go. So it's kind of interesting. We do have third party and obviously fire base, since that's us here in East Summit. So ambulance service, familiar with the equipment, protocols. Obviously, since we're kind of one and the same, we are familiar with how we do things. But there's times, especially on this side of town, where you guys might run in with John Knox. So they have similar equipment, but trying to get familiar with their type of equipment and personnel is pretty important as well. So ask them about their stuff, right, when you're there, even though it may look similar to ours. Ambulance service, personnel with limited EMS training, so those would be the first responders. Can't do a class without stories. So I was out east on 50 Highway. We were mutual aid with, it wasn't even Southern Jack, I forget who it was, but had a vehicle into the back of a semi-truck, open femurs, and we're getting ready to transport. And in our world, we take an extra person, right, in our service, but there, I'm asking for who can go, and they weren't EMTs. They weren't even allowed to get on the ambulance, so they were just basically first responders. That I never experienced that in my career, so I'm used to having minimum EMT everywhere. So, but they were first responders. I took them because that's all we had. They had nobody else to give up, so yeah, that's why we have 3 cameras running. So
oh, one died.
It's right above you. That
It died.
I don't know, it was fully charged, so.
No, it's still got.
Still running, it said like 19 hours when I plugged it in this morning.
Is like the memory card full on it or something?
No. I just can't tell if it's, still recording.
So, I'll have to check periodically, cause again, I'm not used to dealing with GoPros. I mean, this is the first time I've played with those, so my cell phone should definitely be running, so. Obviously, we have fully functional paramedics on the department, so, how many of you are paramedics? Raise your hand. Oh, 4. Okay, sorry. When are you going to school? Okay, all right, we'll work on that. You have plenty of time out here at Station 7. We'll get you handled on that, so, all right. Like Hollywood says, everybody wants an EMT on scene, but as we know, everybody wants a paramedic, all right? And I will. What role does the fire department play in providing emergency medical care? Anybody? Well, make your captain answer.
Initiate for the transporting unit arrives.
Yeah.
AD.
Yeah.
Additional.
They start the care. We're fortunate enough to have enough paramedics. We're on the fire truck. So when we show up, we have paramedic care right there. We have essentially everything that an ambulance has except the ability to transport. Which in some jurisdictions I've heard of people being thrown in a fire truck because they didn't have an ambulance available. I'm sure that would be fine here, but that would be kind of our last choice, right? To be able to do that. Fire service didn't always have EMS, guys. You know that. In my career, it was well established when I started and Jim started, but 15 years before us, it was not. So the majority of our calls, as you guys know, are EMS. So we would not have the jobs, we would not have the size of the department that we have without EMS. So we hear a lot of people poo-pooing it and oh, we need to run more fires, and everybody loves to run more fires, but this is the nature of our business. So this is what we do. What level of emergency medical care does the fire department provide in your jurisdiction? We've already answered that question, especially with 5 paramedics in this room, so, and 1 Explain patient confidentiality requirements. This one, it struck me as weird that it was the first thing they put on here, okay? So we've trained on it. We all know it's the HIPAA law, and that's on the next slides, but what are some situations you guys run into where confidentiality on scene or at the hospital becomes an issue? Former training.
Yeah, neighbors come out of their house and they want to know where are you taking taking Jane to?
What's going on? Yeah. I'm their neighbor. I need to know, right? Yeah. PD kind of needs to know a name, but sometimes PD slips things they shouldn't, and things get into news releases that probably shouldn't. I saw information about a wreck out on 50 Highway 2 weeks ago that had patients' names. How did that get in the paper? They were all minors. They were in the paper. Kind of weird. One that kind of throws me is at the hospital when you're dropping off a patient. You're literally rolling in, and what does the unit secretary always do?
What's their name?
What's their name? Yelling it in the middle of the hallway. And I'm like, anybody's walking by, there's family members, there's anybody who isn't truly involved in care. So be aware of that. Unit secretaries also like to steal your computer, which has a lot of data on it from other patients, especially if it's open. Be careful with that. I doubt anybody's going to get in trouble for that, but they misplace that laptop, it's open, somebody has access to all that information. So take it pretty serious. I like to keep the tablet in my hands because those are my notes, and that's the information I was giving the receiving nurse. It's a law that regulates use, distribution, and storage of patient-protected medical information. Civil and criminal penalties for non-compliance. I think we've only had one issue with that. It was through dispatch here on our department. Correct me, Cap. Anything else you've ever heard of with HIPAA violations here on the department?
No, I think
Several years ago,
people
it was a
here
dispatcher.
take it pretty seriously.
Yeah.
And really from the front office standpoint, that deals with, we deal with the public in a very small time frame. People in the front office, other chief officers, the administrative assistants, they deal with the public over a long period of time, and people will call and regularly request information, and they have to be very careful on who they're talking to, and there's a process for them to go through to request these things, because they're not only dealing with the public of who was involved, dealing with insurance agencies, lawyers,
other providers.
Yeah.
I've been in there when they've come in to get those requests, photo IDs, they're verifying all this stuff, they're getting copies of the photo ID, they're knowing who they're giving this information out to, so they are taking it pretty serious, and like you said, there is a process, and our time with that information is so finite, but we're also in an area, video cameras, anything you say and do can be videotaped, and it can be broadcast, so be careful what you're saying on scene and things like that, just because that information can get out there. Yes, since we provide emergency care, we are supposed to follow HIPAA guidelines. Regulations dictate how and whom the privileged medical information can be shared. Yeah, we have those protocols. Be discreet. Only talk to who needs to know that information. So, release of privileged medical information to others can only be done with the patient's consent, and be familiar with department and authority having jurisdiction guidelines, okay? Know what you can and can't do, all right? Better to say no than not, just like Cap said, the neighbor coming up. You'll have to check with your neighbor on that. For privacy, I can't talk about that. When you list the privacy thing, it kind of shuts them up pretty quick. I mean, you get the super, well, they're my best friend, they're this, that, and the other. Do I need to take care of their house? I'm like, we'll ask them for you, or we'll have a family member come out and talk to you, all right? But our focus should be taking care of that patient, all right? The neighbors, as well wishing as they really are, a lot of times they're just nosy, okay? So that's kind of where this information needs to not be shared. Who has the right to access patient medical information?
Anyone involved in care or billing?
Anyone involved in the care, right? So you can't just go looking up a call that you heard about, right? When we do things of that nature, we do that in a training setting, and they block out the patient's names, and they try to limit knowledge of the actual patient, all right? So it still can be used for training, but you don't need the personals. Communicable diseases. We jump from lawyers to diseases, all right? Identify communicable diseases that first responders commonly encounter. Patients may have communicable diseases which are not always obvious. The old BSI, right? They don't look sick, they may be sick. This class was written before COVID. They don't even mention COVID in there. And any of us who have been in the EMS world during COVID, our whole idea of BSI has changed, all right, and what's out there, so. We're gonna identify common signs and symptoms of communicable disease, discuss body substance isolation, and immunizations. Hepatitis, it's something that can be immunized against. There's a later slide that's gonna go hepatitis A through D. So before we get there, how many of those is there a vaccine for?
I don't recall.
I believe there's only two.
A and B.
A and B. Okay, so we'll get there. All right, so most of us have already, well, at least hepatitis B, we've been immunized for. Hepatitis A is usually contaminated food and water, transmitted by close contact with affected individuals. Fever, abdominal pain, dark urine, yelling in the eyes. Typically, no long-term consequence. It's the least serious form. Basically, it's kind of get it and you heal, and you get over it. All right. Hepatitis B is transmitted through body fluids. All right, can be short or long-term. There are some processes to treat this once it's been identified. It can progress to serious liver failure, similar symptoms to hepatitis A, and it can be a lifelong infection. So that's why we typically take that 3-shot series, okay, because of what we're exposed to. On those lines, anybody here been exposed and had to fill out exposure forms and actually go through the shots?
For hepatitis or for
Anything?
Yes.
Any
like a needle stick?
needle stick, blood on the bare skin?
Yeah.
Yeah. It's a fun process, isn't it?
Yeah.
Yeah. I had a car wreck where a guy, closed head injuries, argumentative, reached up, we're trying to pull him out, and my arms are all scraped up. I've been doing some work around the yard, and he literally had blood all over his hands and scraped with his nails all the way down my arm. Took the patient into the hospital, requested that they draw his blood. They refused. So what's our recourse on that? It's not in the class, but this information's out there.
Come back, tell your captain and put it in the chain.
I wouldn't even leave.
Okay.
Don't even leave. Okay? Get directly on the phone, call your captain through chain of command. They'll get our chiefs involved. If our shift chiefs don't do it, they'll send a training chief out there, and it's a White Act? Ryan White Act, where if you've been exposed as a first responder, they have to draw that blood off that person, okay? So it's not a consent thing, it needs to happen, so.
Once they lose it, which they did.
Just for peace of mind, the hospital refused on me.
Yeah, they lost, huh?
Yeah, and I was getting blood draws and tests for, I think, 6 to 8 months of my career, just having to go in and get that taken care of, so.
It's a lot of fun.
Thank the guys before you, okay, because they fought for that, and yeah, we're exposed in a lot of different ways, and you don't want to take that home to your family, so. and
Why were they refusing to draw?
They didn't think it was enough of an exposure. And when I went into work comp with that, and that doctor was initially agreeing with him, and then I explained his hands were covered in blood, and I had scrapes on my arms from working in the yard, and he literally bloody scraped and drug his hand across my open arm wounds. Yeah, I guess that's an exposure. Okay, well.
Yeah.
Yeah, I would have loved to have had a blood draw so I could have put this behind me quickly instead of taking it down this lengthy process. So know what you can do to protect yourself. Obviously, I should have had something on my arms. I think it was a 100-degree day or whatever, and yeah, so we didn't have anything on our arms at that time. We had bunker pants and helmet, so I didn't have the coat on. So could have protected myself better, but obviously hindsight's always 20/20. There's the hepatitis C and D. Again, C is transmitted through bodily fluids. D is uncommon, and it only occurs in individuals infected with hepatitis B. It kind of makes hepatitis B worse. Vaccines only available for A and B. So this is slides from 2019, so hepatitis C has been in development for a while. I'm wondering, with all the COVID vaccine research, if they've actually gotten better about making a vaccine for hepatitis C. So yeah, we need to be immunized against it. Tuberculosis had taken kind of a backseat early in my career, but now it's on the upswing again because we have a lot of people who weren't immunized. We had people who started developing long-term infections, and tuberculosis has kind of had a resurgence. It's a bacterial infection, affects the respiratory system. It's contagious when airborne, spread when infected persons breathe, cough, or sneeze. Living through COVID, now I want to talk about that. So what did we do with our patients when they were coughing? Put a mask on, all right? Even in N95, it takes care of 95% of the problems, right? That's out there. And then if you put another mask on yourself, you greatly reduce your chances of causing problems with you. When you're in the back of that ambulance, with another step you can do, it's an airborne issue. Vent fan. Yeah, turn on the vent fan, right? More air exchange you can get in there, less stuff dwelling in there. And what do we do when we come back on a call that is pretty suspicious? And we decon it, okay? We're a lot better about that than when we started my career, all right? We'd wipe things down and we'd clean things, but we never really, we didn't aerosolize what we're doing now. So, yeah, we're doing a lot better than we used to. Signs and symptoms of TB: fever, fatigue, chills, weight loss, painful breathing, productive cough that lasts for several weeks. Again, the N95 mask, even if the patient is not known to be infected. There's no widely used vaccine. We test it with our annual skin test or chest x-rays for people who've had certain reactions. HIV. HIV leads to AIDS over a long term. More viral treatments are coming about with HIV as well. So they're suppressing the HIV virus. I don't think it's fully been cured, but they're suppressing it to the point that people can live with it, but they're still somewhat contagious, but it's not developing the phrase the full-blown AIDS, okay, where they get the full system. So they've kept the virus in control with some medications. And so it's actually made it, people are living with it, and the virus is somewhat not even detectable in their system. So weakens the immune system to the point where the whole body's unable to fight off diseases, early symptoms, very similar to viruses. Severe muscle wasting, increased likelihood of other infections. People with HIV are likely to have diseases such as hepatitis and TB. Again, like I said, there was a resurgence in TB. This is part of it, okay? That was a big factor in that to bring that back. Spread through contact with infected blood and bodily fluids. It's less risky to responders than hepatitis and TB, so it's a lot harder to get. Right. Important to practice proper body substance isolation and decontaminate. Medical equipment and surfaces should be decontaminated immediately following the soiling to prevent the spread of infectious diseases to responders and other patients. Early in my career, we'd send somebody out to go get the old backboards and equipment at the hospitals. We just throw them in the back of the truck. You decon them the best you could at the hospital. I mean, but you're in the back of a pickup truck. You only had so much stuff. We wear gloves. That stuff, the blood had been sitting out in the open for a while, but we actually had a board at headquarters. There's a backboard here at this hospital, to hospital. They page out, you'd come in, you'd drive around, you'd go pick up medical equipment, return it back to the station, and you'd clean it up the best you could at the hospital, and you'd come back to the station and decon it there. But we've taken leaps and bounds on our deconning, all right? So is decon just wiping something off? Talk me through, I pick on the EMT, talk me through a good decon. You had a bloody IV start, your medic missed. They dribbled all over the floor, they dribbled up and down the cot. So talk me through what you want to do.
So I would definitely take all the sheets off initially. If there were still sheets on there, check over on top and under of the padding on the cot, check on the floor of the cot, take the cot out, look at the mechanical device, wipe everything down. At that point, if I saw a lot of blood, I'd use the Cavicide spray in there. Basically, take everything apart, just wipe. Just look multiple times for different things.
Hands on as much as you can, wipe as much as you can.
Yeah.
Think about our cleaning solutions, there's a dwell time as well. So if you want to keep it wet for a certain amount of time, then they'll come back to that, but there's dwell time to kill these viruses. And with our cots and crevices, blood gets wedged in those crevices real easy, so try to spray it. And if you're seeing blood dripping out of a connection, work on that joint until you see it clear. Really difficult sometimes to get everything clean, but attention to detail is pretty important. We've all gone in and found where somebody's missed something, and nobody likes that, right? Leave it how you want to find it, okay? There's some multi-drug resistant organisms out there that don't respond to treatment. There's some staph infections that are pretty common. If you were transferring a patient with MRSA, what would your thoughts be for your protection? What do you think?
I mean, a gown wouldn't hurt.
Gown wouldn't hurt.
obviously gloves.
Okay.
And,
Let's go back to my situation. My arms are bare.
Yeah.
So a gown's pretty helpful.
Yeah.
For even that intermittent contact.
right,
Because bouncing around the ambulance, you're gonna be touching things.
Right.
Right, so.
you never know when you're gonna kind of just fall on the patient if you're
Exactly,
leaning over them to grab something.
so. Gown, mask, even eye protection.
Yeah.
Right,
Eye protection.
even though it's bacterial and on the body, I love to turn on the exhaust fan, just fresh air. Clean air makes things happen, okay, keeps things, healthier for you. The resistant bacteria usually occur in healthcare settings, but they can have kind of outbreaks. You'll see them in nursing homes, long-term care facilities. So we'll get that C. diff patient, we'll get several C. diff patients on the floor. Yeah. They can spread easily. Make sure you take your proper BSI, like you just said, right? And definitely sanitize. We wipe things down after a patient and we do our dwell time, but when you have a known, do you take an extra step? Do you do a little more in-depth cleaning?
Yeah,
If you know it was,
Like you said, like COVID stuff, I mean, bringing it back here and hooking everything up, I mean, honestly, if you can suspect COVID.
Yeah.
then definitely come out here and take the time, do a full decon.
Right.
Just do your best.
yeah, that misting system we have in there,
Yeah.
wonderful.
Doesn't take long.
And it's, peace of mind. So
Also can use the bleach wipes at the hospital.
bleach and their cabbie wipes. So bleach tends to dissolve some of our equipment, so people tend to go a little bit too aggressive with the bleach. Captain, you run it, didn't you have to talk to a lot of people about overusing bleach in their solution? I believe you sent an email out several years ago.
Yeah.
They were getting a little bit too aggressive with the bleach.
Yeah, I'm
Instead
trying
of
to
a 10%
remember.
solution, it was probably like 60.
I'm talking about the ones that are at the hospital,
Yeah.
the pre-made ones.
Yeah, I'm trying to remember. Oh, it was, well, people were soaking, seatbelts and stuff from either spine boards or from,
They were literally,
cots.
they would literally throw them in a bucket.
And they would be in there for, sometimes
Days.
people would forget them for days. And they're like, well, that's not,
Yeah.
like, you could
Yeah.
soak them, but you have to take them out and let them dry.
Dry accordingly.
You don't just let them sit in a solution for.
And
40
especially as
days.
concentrated as they were making
Yeah.
it. It's like, little bleach is good, little more bleach is better. I mean, they were cleaning, I mean, I can't fault them for that, but
But it will
they were
break
cleaning to
down.
a fault.
Yeah, it will break down stuff.
Yeah. And you don't want cots and buckles corroding on you, it's kind of important. Again, this was from 2000, or written before 2019, so notice COVID is not up there, but recent North American outbreaks of H1N1, swine flu, avian flu, and others. COVID, where are we at with COVID now, guys? I'm not in the field as much.
It's another common cold here.
Yeah,
You know, it's coming back, like summer COVID is what I read.
it is, and there's a lot, it's a little, it's running through variations, right? So I think this version's a little stronger than what we've been dealing with like for the year before. So from what I've read, again, it's hitting the younger and the older and a little harder than, currently my parents have it, so, and they're in their 80s, so they're healthy people for the most part, but it's taken them a while to kick it. I haven't seen them in 3 weeks, so. There was my father-in-law is still, he's in a nursing home down at the VA, and we frequently get notifications, we're shut down, we're closed. We're not taking visitors because of outbreaks. I'm surprised we haven't seen that here. I haven't heard that as much at our nursing facilities. So, but they're having full wings that are getting shut down, so. Again, proper BSI procedures will keep you safe. If exposed, or possibly exposed, follow the SOPs and testing for treatment, so follow up. All right, if you think you've been exposed, we talked through that a little bit here. Fill out the exposure forms here. If it's something that needs a blood draw, EMTs, if you don't know, work with your paramedic. EMTs, you don't know, call your captain, okay? If the medic's not available, get that ball rolling, okay? Before you leave the hospital, all right? Get that information, get that blood before that patient gets discharged. What are 3 communicable diseases that first responders commonly encounter? One that wasn't even on there, so. COVID, hepatitis, HIV, okay, or even tuberculosis is out there too, so. You can throw the MRSA, you can throw the C. diff,
Yeah.
yeah, you throw all that stuff in there. Explain ways to prevent the spread of communicable diseases during emergency medical care. So we've kind of touched on this throughout that, so. You may be required to be immunized, I can't even talk. You can be immunized against hepatitis B, you have your MMR, tetanus, diphtheria, chickenpox, and influenza. Yeah, the pneumonia vaccine are some of our, for us aging people, right, Jimmy? Right? Okay, for those of us over 50.
I already got it.
What?
Which,
The pneumonia vaccine?
I
Yeah.
thought you were like the
Yeah,
shingles.
Do you get
Yeah.
shingles?
Yeah, I got
And
the
then, and
shingles.
then there's the shingles out there too, which, where do shingles usually come from, guys?
Chickenpox.
Chickenpox.
It's
Right.
from having it, right?
Yeah,
Or
so
not
it's having
having
it. So,
Yeah,
yeah, if you've had chickenpox, you've got the virus, it'll start to pop up. I had shingles once, it was not a fun experience, right? I kind of self-diagnosed and then I had to go in, but definitely had the banding of one dermatome on my body. It was definitely itchy and uncomfortable. My wife had not had chickenpox, so that made for some interesting BSI at my house, okay? So, because obviously she was in her mid-40s at that point and getting chickenpox late in life is horrible, so, yeah. Things we take home to our families, right?
She didn't go to a chickenpox party?
Exactly. I think she tried, but she just didn't get it, so. Body substance isolation, pathogens, organisms that carry disease and can cause infection. They exist in bodily fluids of infected people, transmitted through contact with infected fluids. Bloodborne pathogens are most common, but airborne are also a threat. Exposure. I kind of talked on exposure a little bit. What has to occur for really an exposure to happen? I mean, you can use my example. Yeah, open wound. It's got to be able to have a transport. Your skin does a pretty good job, right? But scrapes, bruises, you guys are all active. You're gonna have scrapes, cuts on your arms, on your fingers, your hands if you're working on anything. So long sleeves, gowns, if you need to, right? Eyes and mouth and nose, something we do a pretty good job, but we don't do a lot of eye protection. Charlie naturally has glasses on. I'm not picking on you for that, but it kind of helps with that eye protection. But what's something you run into a problem with our eye protection, especially in the humid environment we're in Missouri? Yeah, you're trying to work on this patient. You're fogging up, and I haven't found good glasses yet, so I do the best I can to wear eye protection. I really love those, you'll see it later, those masks with the shield, because it allows airflow to happen in there. But standard glasses, I've had nothing but fogging problems my whole career, and then I'm trying to get the glasses off so I can actually see and do my job, and then I'm exposed with whatever's on my hands. Yeah, you can take the gloves off, but it kind of increases your risk. So having the masks around here is a good thing. When do we take BSI precautions?
Gloves for every single patient.
Gloves for every single patient.
And then, as needed,
Yeah.
do more.
Yeah, you're called out on an imminent delivery
Put on gown,
gown.
eye protection.
You're called out on a active COVID patient. Are we in 95? Glasses. Are we gowning as much on that? Usually not. What do you do when you get back? Decon, but what do you do for yourself? Shower, change your uniform. Where do you wash your uniforms? Yeah, here, okay, extractor, okay? Yeah, don't take that stuff home, all right? Believe it or not, there was a time when we didn't have washers and dryers in the station. Bryce, Jimmy and I, we've lived through that, right? We were throwing uniforms away at some points.
Sevens was the first one to get one.
Yeah, so So we were throwing some away, right? Don't wanna take that home and expose your family in your own washer and dryer. Proper hand washing, we've got waterless hand stuff all over. Use it, if that's all you've got, slather your arms with it, right? One thing they don't talk about in here is bed bugs. They talk about communicable diseases, but they don't talk about lice and bed bugs. So you'll run across that in your career, right? And you'll be itching and scratching. I know Charlie's got a little twitch right now just from thinking about it, but yeah. Know if you've been exposed to that. Every once in a while, I mean, did you ever have any notifications where the hospital would call UCAP or this crew was exposed to bed bugs? You found bed bugs on this patient.
No, but I know Chief York did. He would
Yeah.
get a couple of those.
Yeah.
I don't know if bed bugs ever came up, but
Yeah.
we did have the outbreak between 2s and 4s.
Right. At the station.
And that kind of came down to a patient's house.
Yeah.
Yeah.
So.
I do remember doing a mutual aid standby for Kansas City, and in their station they had a whiteboard, and it had known residences with issues at that residences
All bed bugs.
within their first 2 district, which was pretty, good to see that they were.
But that's not, that's known.
That's known, yeah.
So,
And it goes back to, don't just throw stuff on your bags on the ground just to throw. That's why we now have all the bags with straps and stuff, that if you can just wear them as a backpack, then wear it as a backpack.
throwing stuff around, putting it down and whatever. There are services that still use, they like shorts. I like having a little barrier, okay? I mean, just that barrier, our pants have a fluid transfer barrier on it to try to keep stuff off, but after you've washed them so many times, it kind of goes away. But when they're newer, they're kind of moisture wicking, so it kind of keeps stuff off you. But if a house looks like bed bugs, I mean, be aware, all right? Share with the other crews, let them know, wash your stuff. Caps will go out and buy whatever cleaning stuff we need for it. Yeah, we've had outbreaks at the stations because of going through those. I'm surprised they didn't talk about that in this class. Hand washing sounds simple. Again, this is a basic class. Wash for about 30 seconds. Clean well. Work up and down your arms. Brushes, work under the fingernails. Think of it like going to surgery, right? We've all seen plenty of doctors scrubbing in on TV and in movies. So, again, continues, wash for about 30 seconds. If you don't have soap or water, you can always use alcohol-based cleaning solution. And then you can wash afterwards, because even that alcohol stuff, it won't get all the dirt off, kind of just pushes it around a little bit. So I feel like I'm still a little bit dirty. If, say I had grease or something on my hands, you need something to wipe that off the rest of the way. So you'll probably have to follow it up and wash later, but at least get you kind of decontaminated and not contagious. Adequate PPE, prevent transmission. Again, we've talked about that. I love those masks there with the eye shield. Those are very wonderful. Gloves and N95 masks. So adjust to what's needed. And then the bottom line, too much PPE is better than not enough. You don't want to walk in a hazmat suit, but okay, use good judgment, right? Gloves should be worn during patient contact, vinyl or latex, if the patient has allergies. I don't think anybody's using latex gloves anymore. So even in true surgical suites where my part-time job is, it's really hard to find latex gloves. So they're not made as much, right? Change gloves between patients when you're grabbing gear. Don't drive the ambulance with gloves on, okay? Okay, bad idea, all right? Just don't do that. If you're grabbing things, you can peel back the glove, open something, peel the glove back up. I mean, there's ways you can do it, right? Always best to change gloves, but you guys know how to properly take off gloves. Splash safety, I don't think you necessarily have to go to 95 for splash safety, but the fluid shield masks, and the other masks are pretty good, but if there's a respiratory issue, you can go to the N95. The Burke Shield, I had to look that up. What are those? Anybody know what a Burke Shield is?
Horrible.
They're these little flip down little plastic things under your helmet, on your fire helmet.
Oh, those shields. Oh,
Yeah.
no.
Yeah, I had to look it up because I was like, I haven't heard that phrase. Even our drop down goggles are good for, on our helmets are really good for extrication and things of that nature, but they're attached to the helmet. So you're using that. Yeah, have another set in your pocket or something like that so that you can always flip that on if you need to. Masks protect against respiratory hazard, airborne pathogens, bodily fluids. Having things squirt in your face is not good, okay? Okay, that's all we're gonna say. Surgical masks typically suffice with contact with blood or bodily fluids. If they're already suspected, you can always upgrade your PPE. There's testing for N95 masks. Are we still testing on those? Or do we do it at the same time we do?
We've actually.
Kind of backed off on that.
I
This
think-
is old knowledge, so.
Yeah, the last, I mean, I think I was here maybe a year or two was the last time that we did N95 actual true.
Yeah, we'd actually fit them and you'd test and they'd do the scent test
Yeah.
and so
Yeah.
forth. Yeah,
Even during COVID, we didn't do it.
right. You found a mask that worked and it was put on a lot, so.
Yeah.
The gowns, we talked about that, trauma and emergency childbirth. Somebody was laughing at me when I put on my bunker pants to go to an imminent delivery, okay? They didn't laugh afterwards, okay? Lots of fluids, all right? Lots of fluids, and we were in a bathroom, we were laying down in it, and you had to get in it. So, it's just what it is. Spare uniforms, keep plenty of uniforms around. The department will buy you whatever you need, right? If you've got trash uniforms, get rid of it. They can get it replaced. I've never heard of anybody getting in trouble for tossing a uniform that was decontaminated and trashed. Okay, if it's beyond deconning, get rid of it, all right? Decontaminating equipment, we have dedicated places now. In the past, we've cleaned laryngoscope blades in the sink. There weren't dedicated sinks in some of these stations. You try to do it in the bay sink the best you could, but we didn't have the dedicated cleaning areas that we're putting into all the stations now. So do that dwell time, follow directions on the bottle, make sure you do it properly. There's our extractors that you talked about. Obviously it talks about not using it in the kitchen or bathroom. Definitely don't take it home. Properly disposing of our disposable items. Sharps bins, what are those designed for? Sharps. What do you find stuffed in there all the time? Alcohol wipes, any 4x4, glove, they treat it like a trash can, right? You try to put something in there. Yeah, say you catch a call early, last rotation, last crew, they stuffed it, you're trying to put a needle in there, I've had them pop out. And I've looked in there and they're full of gloves, 4x4s. Anything that has blood on it, they're shoving in the sharps container, right? Sharps are for sharps, right? And for medications, right? We have red decon bags for that very reason, okay? We have the containers at the station. Cool. Put that stuff in the bag that's not sharp and it's gonna cut you. Put it in there, okay? Let sharps be sharps, all right? You guys need to review body substance isolation. You think you got it? And I think we know what type of PPE do responders typically use during emergency medical calls. We adjust to what we need, right? Minimum gloves, masks, and we just work our way up. Explain the process of patient assessment. We're about halfway through on this. You you got a responsive patient, your priorities need to be the airway, breathing, and circulation. Unresponsive, check for circulation, airway, and breathing. Why is there a difference?
Responsive patients need to be checked for a pulse.
Responsive patients need to be checked for unresponsive. Unresponsive definitely need to be checked for a pulse quickly, right? Because that's going to dictate a lot of things pretty fast. If they're responsive, we can evaluate an airway, but if they're responsive, they typically are protecting their own airway, right? Is pulse present or no pulse? Jump immediately to chest compressions, open the airway, and ventilate the patient. Airway, very basic stuff. If tongue, foreign object, or fluid obstructs the airway, air cannot travel in and out. Being able to breathe is a good thing, right? So open up that airway, secure that airway. If the patient appears to talk, breathing without difficulty, assume the airway is clear, right? If the patient's unresponsive, the airway may need to be opened. What are some basic ways we can open up an airway in an unresponsive patient? Head tilt, chin lift, or jaw thrust. Okay. Why have they kind of gone away from the head tilt, chin lift?
Possible neck injuries.
Possible neck injuries, right? Unknowns, right? Jaw thrust works pretty well too, right? And head tilt, chin lift, when we mess with the mannequin, it's not get behind their back and lift their C-spine up. It's literally just lift their jaw, okay? Open up that airway. He's demonstrating the look, listen, and feel, trying to assess the breathing. Patient's nose, listen and feel nose and mouth to see if any air is coming out. If you're not sure, go ahead and start care, right? Circulation. Where do we check for a pulse?
Carotid.
Carotid, okay. What are some other options? Femoral? Radial, okay. Dorsal. And then the paramedics, what are some times when I really want to know if I've got a distal pulse in that foot?
Lower extremity injuries.
Lower extremity injuries, that's one. There's a few others.
Femur fracture?
Femur fracture, right? So they could be completely compromised there, right? Let's, it's something we get a lot of transfers for. Thank you. You start feeling that tearing sensation in your chest. Yeah, they describe that. You get the AAAs. You lose those pulses, you fully ruptured. Okay, so you're not getting any circulation down there. Time to divert, right? So if I've got a AAA that I'm abdominal aortic aneurysm, if I've got one of those, I'm going to check off where my pulse is, mark it with a pin. So if things start to change, you know where you found it before, and then you can establish that, okay? If you do not have a radial pulse, are you going to believe that the patient is pulseless?
Hypotensive.
Yeah, they could be hypotension. Thank you. Radial artery takes stronger blood flow for the pulse to be felt than at the carotid. ABCs of patient assessment refer to. Thank you. We're going to describe cardiopulmonary resuscitation. Clinical death and biological death. Clinical death, they have no pulse in there. Have you ever seen a Princess Bride? They're nearly dead. Okay? They're nearly dead. They're in that time window where, what is our time window of pulseless, not breathing, to usually prevent irreversible harm?
3 to 5 minutes?
3 to 5 minutes, or upwards of 7, depending on what literature you read. Okay? So that's your clinical death. You're in that time frame, right? Biological death is when you've actually go beyond that, and you're actually causing more damage and irreversible damage. All right. Defibrillation. What does defibrillation do? No paramedic answer. Sorry, I'm picking on my EMT. What does defibrillation do for the heart?
Restarts the heart. It like essentially just provides electrical current through the heart.
Does it restart or does it reset? Well, it resets. Think of it like when your phone's acting up or your GoPro camera's acting up, you restart it, okay? The heart's quivering, heart's doing funky things. It's not beating effectively and organized. You overwhelm the heart with electricity and you reset it, okay? The heart's got its own internal pacemaker. It'll want to restart on its own, we hope. So we're wiping out those bizarre signals and you hope it's a reset, okay? So the movies and the jump start, yeah, just doesn't work, right?
The way I think about it, Sean, is you ever turn on an old Nintendo or an old Super Nintendo, and you turn it on and you just get it.
Yeah.
It's on, but the electrical components are just giving you just lines and
Yeah, that's why I
static.
like,
Hit that reset button and it works. That's the defibrillation.
yeah, that's what I like to talk about with, when your
It's the
phone's,
exact
when your
same.
phone's acting up or your computer's acting up. Well, did you restart it? It resets things, right? And you're resetting the heart, okay? So that's what defibrillation does. It's critical to perform as quickly as possible because there is only so much time that the heart will stay in that stage where it's ready to receive that electricity. Advanced EMS may take several minutes to arrive on scene. We're fortunate. We have stuff with us, and EMPs have our monitors do both AED and manual defibrillation, so we have that capability even if there's not a paramedic on scene, which is kind of rare nowadays. Just because they're pulseless, non-breathing doesn't mean a defibrillation needs to happen. AED, not every heart rhythm requires that. So when we start to go through ACLS, pay attention, and you'll see there's certain rhythms out there that don't require electricity. Cardiopulmonary resuscitation, physically forcing blood through the body. You're a pump, right? You're providing artificial respirations. Layperson CPR is performed differently than CPR for healthcare providers. What's different about it?
Layperson CPR is just compressions,
They also can have ventilations, right?
But I guess it depends on where you're learning it from. The last I heard was a lot of people there was too many steps and people were afraid of doing things wrong, so they emphasized just compressions.
They do emphasize compression-only CPR, depending on which brand or which label of CPR, whether you're Red Cross
or
or AHA.
Yeah,
But
I don't remember.
they call it hands-only CPR at one point. I've called it compression-only CPR. I'm sorry, call and pump was kind of our, we were teaching that for a while. I taught a lot of that. The biggest difference between healthcare provider and non-healthcare provider is advanced airways when you start doing that, because layperson, they don't have those advanced airways, so they're gonna do 30 compressions, 2 breaths, 30 compressions, 2 breaths, or continuous compressions. Advanced providers, once you get that airway in place, you do continuous compressions and you breathe how often? Every how many seconds?
5 or 6.
6. I would go 6. That's a good answer. Okay, every 6 seconds. Okay. All right. Oh, hey, you have to become CPR certified. You guys got that?
Yes.
AHA and Red Cross. To make things easier, AHA was a little difficult for me to try to teach outside courses with our affiliation with the department and CJC. So I went out and I got Red Cross. I like some of their classes a little better. They do a lot more practical stuff. They, in their classes, they talk about CPR in pregnancy. They talk a lot about Narcan and a few other things that are just now coming over to the AHA side. So it's nice having 2 entities that can kind of work back and forth, and I have to be careful when I'm teaching the class to remember, oh wait, this is an AHA class or this is a Red Cross class. Gotta make sure I adjust for that. So, where are AEDs located around our city besides on our fire trucks? Churches,
School, public buildings.
public entities, schools,
Several businesses.
businesses, pools. Some jurisdictions have them in police cars, right? I don't think we are doing that yet.
I
But
think some of them do.
yeah, some do.
Oh, it's not all of them.
It's not all of them, but they do have some around. They've got them in the jails. Sports venues, I've got it at my soccer fields. I got some AEDs donated. In fact, I got them donated to all venues out there. So there's AEDs available. So people know how to use it. So AEDs are pretty simple to use. In Missouri, you might not know this, but you do not have to have any license or training to use an AED. There's state statute that allows you to use it, all right? All you have to do is listen to the prompts. It's really hard to mess it up, right? You can't hurt somebody by doing it. Even if you hook it up to somebody who has a pulse, the machine's gonna protect you and not do it, all right? So, Missouri's wonderful about that. Components of CPR. Can we use CPR on that table very effectively? Probably not, especially since it's leaning crooked, right? It is a hard surface, and it is the right height for us, but is that table a sturdy surface to be doing that? Probably not. So we'll test it out when we do our practical. If not, we'll go on the floor. I put it up on the table so cameras can see us, high cameras, right? Which we love, right? Again, you're forcing the heart to circulate blood through the body. Patient survivability during cardiac arrest improves with early administration of compressions. When I teach CPR classes, I always talk to people, I'm like, err on the side of starting compressions. You can't get that time back. The sooner you can get compressions going, you're buying the person time, okay? You might not convert that heart rhythm, but you're circulating that blood and oxygen. You're giving them a chance until more advanced care can arrive, or an AED arrives, or something else can occur. But you're kind of stopping that window of biological death at that point. You're giving them back to that clinical time, okay? Obviously, if they're saying ow, you're gonna stop, all right? I'm sure Jimmy's witnessed people having CPR done to them that didn't need it as well. Do you remember a few, car wreck? Yeah, I was hearing a patient say ow, ow, ow. And I'm like, you can stop. I'm like, but I haven't gotten to 30 yet. Oh gosh. But I've heard that twice. One was in a nursing facility at the end of the hall, and we're walking down carrying all our gear, and I'm hearing ow, ow, ow. I'm thinking it's the person providing care. No, it was a patient. And so, enough said, right? Cardiac arrest events are stressful for all involved. They are typically unexpected. CPR may not be in progress when you arrive on scene. First priority after donning PPE is determine the condition of the patient. Are they viable, right? How long have they been down? CPR should not be administered to those with signs of irreversible death. What are those signs? Lividity, and what else? Fixed dilated pupils. Rigor. Explain rigor. What is rigor?
Your body's just become like stiff as a board.
Stiff as a board, literally. I walked into a nursing home doing compressions, and it was a special needs nursing home up near Truman. And the person doing compressions, the arm was frozen and was like hitting them in the back of the head as they were doing compressions. And I asked their special needs facility, they could have some developmental disabilities, that could be normal. And they're like, oh, that's not normal. That was rigor, okay? So we stopped compressions at that point. But I had to look at the whole situation and know they were getting hit in the back of the head with the arm, but they were trying to save the patient. So I can't fault them for that. They were rather trying to do something rather than nothing. But obviously there's injuries that are not sustainable with life, like decapitation, exsanguination. Yeah, they've lost their entire leg. Came across a patient that was sitting up that had half their body removed by a pole. And yeah, obviously we're not doing compressions on that. So that was a motorcycle fire that became a code. That was a fun night. You remember that one?
I didn't go, I remember hearing it.
Yeah.
I didn't go there,
Yeah.
thankfully.
Memories, right?
Yeah.
Layperson CPR, just like Charlie said, greater emphasis on compression than on ventilations. Compression only CPR is effective and provides some air movement into and out of the lungs. Just by pushing on the chest acts like a bellows. It's moving in and out. There's full CPR with chest compressions and rescue breathing. Obviously most responders are certified in CPR and BLS for healthcare providers. chest compressions for adults. Determine consciousness, determine the patient has a pulse. Start compressions if no pulse is found within 10 seconds. At the carotid artery, not the radial, okay? You guys are very good at finding femoral pulses. Usually it's not something I jump for, but I do know where to look for it, but I'm a whole lot more comfortable going up here for that carotid, right? It's less invasive, you get a lot less question as to what's going on. They like you to notify communication. You'll see that bullet point. Let your communication know that you've got a code so they can upgrade their alarm, basically, to bring more assistance to you. Patients must be lying on their back on a hard surface, not on a bed, not on a couch, right? It doesn't work very well. If you can't get the patient moved off that surface, what's something we can do to give us a rigid surface to push on? Yeah, put a backboard under it. I teach a lot of offices, and there's a lot of small staff members at these offices, and I'll have them put like a metal tray up under. Anybody can roll a person up and put that metal tray under it. It gives them something to push against. A large stainless steel backing for them to do compressions on. So in our world, if the patient's wedged between the toilet and the wall, what's probably the best thing for us to do? Get them out.
Area where we can work.
Take the time, move equipment, give yourself room to work, right? So we can do, what system are we doing now when we're setting everything? Our pit crew, thank you. You know what I was after? We need room for that, right? To make it work effectively. Jimmy, Bryce, and I, Charlie has too, we work codes where, where's the airway bag? Oh wait, they put it down behind the couch. Or, yeah, much smoother when you have room to work, right? Correct location to administer compressions. What are our landmarks for compressions?
Between the nipples.
Between the nipples. What if it's a 48-year-old woman with very large chest? Would you go for the nipples?
There's nowhere to aim, really.
You know where to aim, right? Well, teaching classes.
Yeah.
The nipple line, it moves, okay? Bottom line, it moves. Look at the base of the armpit, center of the sternum, right? In between the chin and the belly button. Base of the armpit kind of gets you in the right spot, doesn't it? Right? The old days, they used to teach the tracing of the ribs. You kind of feel that. You feel that notch, then you go above it, right? All to get your hand in the right spot. Nipple line, I've seen somebody trying to do compressions as a layperson on a woman with a big chest and they were on her stomach. Okay? So I don't like how they say that, but yeah, but
Sternum's easy to find.
it is. Even fat people, you can find the sternum. Right. Another bird at the window. Pick them on their back, open up the airway the best you can, straighten your elbows, get as close to the patient. The guy kind of looks like McCoolidge, a younger McCoolidge in that video.
With haircut.
Yeah. Close to the patient, get your knees as close as possible, use your body weight to do this. Again, I teach a lot of people who aren't very big, so they have problems doing it, or they might be elderly, and they have a lot of trouble with the strength to be able to do a compression. Compressions, interlace those fingers, push with the heel of your hand. I know we have the Lucas, but there's gonna be times Lucas isn't available, we're not quite there yet, right?
Or it just doesn't fit.
Doesn't fit. I run across that too. And I'm doing manual compressions in a breezeway while some people are screaming and trying to, yeah, it was a challenging code, let's just say that. So we can talk about that later. So, we're gonna push 2 to 2.5 inches. How fast are we gonna push, guys? 100 to 120, right? The old songs, you've got them, the Staying Alive, newer generation, Baby Shark, whatever you want to say, okay? Sorry?
The Imperial March.
The Imperial March. I've heard When the Saints Go Marching In, or Another One Bites the Dust. I haven't heard the Imperial March, that one's new, so, all right? So, if you got the Star Wars fans, okay? Now, is it when he's, does it ever change pace in the Imperial March? I thought, depending on the scene, I thought it got faster.
I've just watched a video where they were doing it to that, and it was hitting that number.
Okay, all right. Good to know. Our monitors have metronomes in it, so, and it's designed specifically to pierce through background noise. So they pick that tone specifically so you could actually hear it. When I'm doing a class of multiple people using an AED and they pause to do compressions, it's amazing. People are doing compressions. Initially, they're all pretty out of sync, and then all of a sudden, everybody's doing it once. So it's kind of interesting. Make sure on your compressions, you come all the way back to the top. We don't want to do compressions keeping that chest crushed. You need to let that heart refill so you can actually get the blood to where it needs to go. Give your 2 breaths, and then while holding the nose, and then continue. There's our 100 to 120 beats per minute. Continue until the patient moves. I'm glad they put that in there. Begins breathing normally. What is normal breathing?
12 to 20.
12 to 20 a minute. But what does it look like on the patient? Is it kind of a gasp? Is it
Chest right.
Cool chest rising.
good chest rise? Okay.
Normal depth.
Yeah, normal depth. Gasping, is that normal breathing? No, that's agonal breathing. Okay. We're not going to go into Kussmaul and all the other fun stuff. Jimmy, I know you want to talk about that. I can tell. I can hear you over there. All right, we're not going to go there. All right. Or Shane Stokes. That one acting up. Did that one overheat or something? That one shut down?
That was still recording, so that's
Okay.
good.
All right. While performing chest compressions, it's also common to hear or feel a patient's ribs break due to the pressure. While this sensation is not present or pleasant, it is a sign of quality compressions, they say. And you should not discourage you from continuing. Typically, just like happened to our Chiefs player, is it typically a fracture or is it something else? When you're pushing on that chest, what connects bone to bone? Cartilage. You're typically popping that cartilage. Very elderly people, you might break a bone, but a lot of times you're going to dislocate that. It feels like a zipper when you push on that chest, and it's a gross feeling, right? But it actually makes it easier to do compressions. Right? You're not hurting them; they can heal from that. Not having a pulse is bad. You can quote me on that. Right? Chest compressions for children. You're going to determine consciousness. Again, unresponsive. Check for a pulse at the carotid or brachial artery. No pulse, same thing, move the patient to a solid surface and begin compressions. What are we going to do different compression-wise with children as opposed to adults? What's the variation? Depth, yeah. We're going to get to that in the next slide. Again, update dispatch. They want you to tell dispatch that you actually have cardiac arrest. Larger children, you can use 2 hands. You just don't push as deep. And then smaller children can use 1 hand. Third of the depth of the chest. I like when American Heart came out with that instead of all those depth ranges. Remember the 1 inch Jimmy, the 1.5, the 2 to 2.5. A third of the depth of the chest is pretty nice to know for a child, right? You're still going to do the same rate. When you're breathing in the mouth, you might have to cover mouth and nose depending on the size of the child or infant. Adult techniques can be used on larger children. They didn't even talk about choking in this, so they kind of, they discussed checking the airway with infant, but they did not come back with choking, and we're not gonna go there because I'm teaching the curriculum that it's, right? Because that's what the class requires. Infants, how do you determine mental status on an infant? I mean, they can be altered, but what are you looking for with an infant?
Strong pride.
Are they crying?
Awareness of personnel.
Yeah, they're moving around.
Well, the
Are they
parents
just-
know
How
now.
old?
Parents say they're acting weird.
I was gonna say tracking you, depending on how
Tracking you,
old.
yeah.
So.
Most cardiac arrests for infants are due to airway obstructions. So look before you start blowing, right? Do we do the old blind finger sweep? Do you guys know? Even on adults, we don't do that. If you see it, go after it. If you don't, try to breathe around it, right? Check for a pulse at the brachial artery. Why on infants do they go to the brachial as opposed to the carotid? Think of the anatomy of the kid.
There's more cartilage and less bone.
Yeah, and they're short and chunky right there. Really hard to feel a pulse in there, okay? So brachial. Obviously no pulse, begin compressions. Have another one, call dispatch. Again, they keep repeating that. So let dispatch know that you're doing cardiac arrest. Again, 100 to 120 beats per minute. A third of the depth of the chest. Every time you go to breathe with the patient, check for an obstructing item. Continue compressions until the infant begins to move, regains consciousness, until responders arrive with more training. And you do compressions with fingers. We're not going to do infant in here, it wasn't required. So, infants respond really well to compressions, right? So even after, if they've got a low heart rate right after birth, we're doing compressions. They respond quickly to aggressive treatment, right? So they didn't mention it here, but as a lay person, that's the only time you delay calling 911. You do 2 minutes of CPR before you go call. So because it does such a good job for them. What's the purpose of performing chest compressions during CPR? Yep, moving the blood and oxygen. What's different about chest compressions for infants and adults, or young children rather than adults?
Ventilation rate.
Depth, ventilation, depth of compressions, same rates. Okay. Discontinuing CPR. We hope that a patient moves and regains consciousness. That's what we're all after, right? The patient has a pulse, the patient's breathing. You hand over care to someone with a higher level of training, or a physician instructs you to stop. Right? Follow our protocols as well. If it's been a certain amount of time, they've been in a certain rhythm, we know when we can discontinue. We're not going to go deep into that now, but do we typically discontinue in a public venue for our protocols? No. Okay. Good answer. Cardiac events are emotional, especially for the family. You suddenly have to deal with the family as well. We do a really good job with our officers and trying to handle that part of it, and we can focus on doing what we need to do. But you're a pumper crew, you're there by yourself. Captain's the only paramedic. Guess what? You're gonna have to jump into that role and kind of help manage the family a little bit, right? At least so they don't interfere with what you're trying to accomplish. Because the captain needs to suddenly take off the captain hat and start being a paramedic, all right? People may be mad if you're deciding not to work them, right? So that's why they send PD on all these, right? Because it's a highly emotionally charged event. So get PD there. Calmly speak to the family and friends of the deceased. They're still in shock. You may know they're in full rigor and that there's nothing we can do. How you say that affects their response, right? If you're compassionate about it, you try to, they're in full rigor, they've been down a long time, they're showing signs of irreversible death, and we can't get them back. So sometimes they're still gonna want you to do things. At times we've taken them, we call them kind of show codes, we're doing what we can, we get them back to the ambulance, we call the hospital just to get them out of that charged environment. We'll downgrade, we won't be going to the hospital, lights and siren, but there's things you can do to try to help the family a little bit. So that's why we're paid to think on our feet. I think we already know what point you should discontinue CPR. Controlling bleeding, we're close. Blood transports oxygen and nutrients to cells, maintaining blood flow and volume is important. Be prepared to control bleeding in victims. Blood inside's good, outside's usually bad. Different types of external bleeding, lacerations, punctures, and abrasions. Arteries transport blood away from the heart. How do you know it's arterial bleeding? Spurting, okay. Is there a color change of the blood? It's bright or red. Yeah.
Never actually seen it be like mush.
It's bright red. Yeah, it's bright red. And they talk about a slide later as if the longer you let it go on, the less pumping there is. So the less aggressive the, obviously, because their volume is decreased. bright red, spurting, pulsing blood. Force decreases, significant blood, red, elevated. I like how they say true medical emergency because we run a lot of non-medical emergencies, right? Don't delay transporting, lots of pressure, all right? If you putting direct pressure on that wound is not stopping it, what's another step you can do?
Elevation, tourniquet.
Elevation, they shy away from tourniquet on this because it's a basic class, but I like where you're going with that. Tourniquet early is wonderful for advanced providers, but raising, going for a pressure point, maybe go to where you normally feel a pulse, push on that, right? Try to slow that bleeding down, okay? But yes, tourniquet, I agree, okay. Veins move blood back to the heart. They're usually, it's a darker shade of red, easier to control. Again, direct pressure. Capillary bleeding, it's kind of the oozing between the arteries and veins where oxygen, nutrients, and blood are transported to the cells. Carbon dioxide and waste are removed from the body. Blood moves more slowly. You get kind of the ooze. Think of it like the rug burn. Kind of get that ooze. They're very superficial. A lot of times they stop on their own, but it's a great opportunity for infection. So they talk about cleaning it. So, what are the 3 types of external bleeding?
Oh, sorry.
Oh, wait, external, but.
External. External bleeding. It said laceration,
Oh,
puncture,
okay,
and
yeah,
abrasion.
yeah, you're right.
Laceration, puncture, and abrasion. So,
Something like that.
I don't think there's a review question about the arterial and non-arterial. Okay, so I guess there is. I read this. I just didn't remember. I don't memorize all of them. So, and I usually have a screen tell me what the next slide is, but it's hidden over there. For some reason, that TV's not working. What's an example of arterial bleeding?
Spurting.
Red.
Spurting, thank you. Arterial or venous
Blood red,
Or
and capillary.
superficial.
May not bleed much at all.
All right, controlling internal bleeding, external bleeding. Direct pressure, elevation, combination of both, follow medical protocols, proper PPE must be used. Trained medical professionals use tourniquets, so you gotta have trained, right? Remember, this isn't anybody class, right? Pressure with the gloved hand until you can get a dressing available. If it's spurting, get a hand on it, okay, gloved hand, please. All right, blood soaks through, apply dressings on top. Why do we do that? Why do we pile dressings on top as opposed to applying new?
So any clotting that has occurred doesn't get ripped off.
Exactly. You want to build upon what you've done, right? If blood stops soaking through, you've done a pretty good job, right? Apply direct pressure over the glove hand immediately, like I said. Blood obviously leaves quickly. It's a real emergency, like they said earlier on the slide, as opposed to a fake emergency. Apply bandages and dressings after they're located and opened. So people are coming at the kid. If you're seeing it, get your hand on it, okay? Start asking for equipment, right? Elevation, conjunction with direct pressure, gravity's helping you, may not be possible in some instances. What bleeding methods can be used to control external bleeding?
Direct pressure elevation. Tourniquets by trained
Yep.
professionals.
Internal bleeding. Spaces in the body can hold a considerable amount of blood there before there's evidence of a problem. What area of the body does this more than any? Abdomen, right? Okay, cannot be seen externally. Things you may see though are significant bruising or other indications. So is that why they call it exposing? So you can actually see some of that. You got a patient talking to you normal, you pull up their shirt and you see a large stripe across their belly that's heavily bruised. Your index of suspicion better go up, right?
or unexplained hypotension.
Yeah.
Abdominal bleeding.
Absolutely. Bleeding from things where they're not supposed to come from, like from the mouth, nose, rectum, stool, urine. painful, swollen, rigid abdomen, vomiting of like coffee browns, okay, and signs of shock. Traumatic causes: gunshot, stab wounds, motor vehicle fall, medical issues at AAA we talked about, rupture of organs, uncontrolled internal bleedings, and medical emergency. Time to go, right? Not many things we can do for internal bleeding except get them fluid and get them to the hospital. I'm not gonna put direct pressure on it. We need to get moving, right? That's when our time window needs to be pretty short. So that's why we do rapid trauma assessments, get the patient going. Signs and symptoms of internal bleeding, anybody?
Unexplained hypertension.
Unexplained hypertension, you stole Charlie's. He taught you something. Bruising,
Tenderness.
rigidity, tenderness, got it.
Pulsating, yes.
That's bad, that's bad. Explain shock management, that's our objective. Body's unable to regulate itself and maintain normal function. This is the last section. Body's unable to supply enough blood to keep vital organs functioning. There's hypovolemic, bulimic, neurogenic, and cardiogenic. They explain on the other slides. Hypovolemic, Charlie's low blood volume, right? What's neurogenic shock? It's okay if something's happened to the nervous system, they actually cause the nervous system, all the vessels to expand, right? So they've had a, yes, thank you, you're welcome, that's why, teamwork, right? Cardiogenic, what's cardiogenic shock? Heart stops, right? You're not getting around. Types of shock as well, you've got trauma, other medical emergencies, anaphylactic, and septic. Is there much we can do for septic?
Not an emergency setting.
Not an emergency setting. We do volume replacement, we can do supportive care. We've got to get them moving, but we need to be able to recognize that is truly an emergency. We're seeing more of that because we're seeing some of those resistant bacterial strains out there. So yeah, people are getting septic that usually weren't, so big increase in that. Hypovolemic, like we talked about, low blood volume. Cardiogenic, so heart's unable to force blood to the tissues, or it's not pumping properly. They can be in cardiogenic shock during a heart attack. How would that, they've not fully gone into an arrest, how would a heart attack affect and cause them to have cardiogenic shock? Not, you partially damage the hearts, you've got half a pump, you're not working effectively, okay? That's why they kind of get that pale, clammy look, and when those across the room, yeah, we can tell they're having a heart attack kind of things. You know, things I did not experience during mine, so. Neurogenic shock, I'll let you read this one. Okay, what do you think?
Blood vessels expand and contract due to brain signals and regulate blood flow. Occurs when there is damage to brain, spinal cord, or other nerves that regulate blood vessels. Typically a result of overexpansion of blood vessels and decreased blood pressure. It's a container issue. It's usually caused by spinal trauma or head injuries.
What can we do about this?
Dopamine?
Transport fluids, and try to prevent further damage. That's all we can do, right? Have you ever had a neurogenic shock, either of you? I haven't.
I don't think I've ever.
So, I was gonna ask you, cause you just remember what it was.
So,
It's kind of rare, so. Anaphylactic, obviously, we know that, due to allergens. Septic shock, obviously, is an infection. Most common types of shock, those were on those first slide.
Hypovolemic,
Cardiogenic and neurogenic. Even though it's most common, not many of us have seen it. Yeah, I see anaphylactic shock before I've seen neuro.
Yeah.
So, yeah, I've definitely seen septic, so I need to check your sources, right? I didn't write the class, I'm just reporting it. Signs and symptoms of shock: internal body functions are carefully adjusted to achieve optimal results at homeostasis. Negative condition, body adjusts accordingly. Body may not be able to maintain normal operations. Body gradually exhibits negative effects of the condition. So they kind of spiral. So So you've got the early signs of shock, and then you've got late signs of shock. Would rapid heart rate be an early or late sign?
Early.
Probably an early, okay. Pale, cool, moist skin, what do you think? Early or late?
Early.
Could be either.
Both.
Could be both, yep. Dilated pupils, I call it late. Loss of consciousness better be late, okay? If it happens early. The dizziness could be early, right? Rapid breathing, could be kind of anywhere, depending on the type of shock they're having. Confusion, more late. Nausea and vomiting,
Either.
could be either. We just went through that, so that, okay. Okay, all right, you guys agree? All right, patients exhibiting signs and symptoms of shock should be treated immediately and prepared for transport. Paramedic treatment is important, but should not delay transport to a hospital. That means you can do it all by yourself, right? Call the EMT, right? Okay, just like Hollywood says, right? Get me an EMT, okay? Transport to the hospital is best treatment in most cases and should never be delayed. Wounds, treat the wounds, oxygenate as needed. That's why we have 3 cameras. Control bleeding immediately. EMTs and paramedics are right. Battery? Okay. What should you do to a patient who goes into shock? This is the last slide.
Oxygenate.
Hopefully that's still going. Okay, perfect. Oxygen, elevate, transport quickly. Any questions about this content? All right. Take 5 minutes to go to the bathroom, come back, we're gonna do a quick written test. I've talked about test security, it's up there on the table, you guys haven't seen it, right? Okay. Give you the test, and then everybody has to do 2 minutes of CPR per the thing, and we're gonna hook up the oxygen. I brought the airway kit in here, and we're gonna hook up an non-rebreather to the patient. Okay? All right? I almost didn't hook up my camera.
Probably all, yeah, those went quick.
Yeah,
That one went really quick. This one almost made it.
yeah.
It's crazy how hot these things get.
Yeah, how's it overheating?
I don't know. When I bought them, I was really shocked at how hot that they got. That one was like on fire, but the other band did.
Interesting. Okay, we're right at an hour and a half. I have to have a 2-hour class, so.
Got you.
Okay, by the time we get the quiz and do our practicals, I think we'll be good.
Yeah.
All I could read the slides a little more to you.
Little
Tried to
review session.
make it entertaining.
Little review session before the test.
Tried to make it entertaining.
It's good. Stories are perfect. That's what gets me. I like stories.
Yeah.
Keeps me awake.
I think properly applied, because they stick in your head,
Yeah. And it relates to the material, so,
stick in your head, and as long as they're not too long.
yeah.
All right, Jimmy, I have half an hour, I have to, more material I gotta go over. So it's gonna take us half an hour to do the test,
Okay,
and everybody do,
doesn't matter to me.
I mean, just 2 minutes of CPR with 5 people, that's 10 minutes alone, right?
Yeah. Yeah,
Simple as that.
yeah. That metrodome really does work.
Yeah, it does a pretty good job.
Yeah.
All right, you haven't heard the metronome?
I have not.
But some places, like, carry it on like the captain's clipboard.
Yeah.
They put a stopwatch and
I got you.
a metrodome on it.
I need to copy another test. I was only planning for 3 people, and so I printed 4. So. Bryce doesn't need a test. Actually, let me shoot a copy of it. 'Cause- let's see if I can shoot it here.
Yeah.
Adam cobwebs have formed on this printer. Because you're on the sheet. Sorry.
The 12th.
11.
What? Colton?
Charlie. Come over and we'll start. Bring your skill sheets and get your names on the top of them. Thank you, Kat. Touch and go. So
I got 100 in hazmat the other day.
part of the criteria is you have to discreetly give scores to students.
Oh.
That's what it said.
Oh, really?
Yeah, you did.
All
So,
right.
you did well.
Oh,
How's that? Is that discreet enough?
that's discreet.
All right. Okay, so let's start off with CPR. I don't know if doing compressions on this is going to be a good thing, but I have to turn that thing around. Let me turn this.
That'll work.
Good enough? Yeah. Thanks, Jim. Yes, make sure. I'll do that. All right. Who's going first on CPR?
I'll go.
All right, so get her done. Okay. All right, walk up just like any scene.
BSI, scene
BSI,
safe.
perfect.
PPE.
Yep.
Scan, make sure everything's safe. See if
Yep.
anything's going on, sir. Feel for a pulse.
You have no response?
No chest rise or fall. Start doing CPR.
Is there anything you might want to have your coworkers get or friends?
I'm gonna have call 911
Yeah,
and then get an AED.
absolutely.
I guess in this instance we are 911. 911.
Exactly.
Not like,
We have to assume that we're.
not like AHA.
Yes, assume you are not a healthcare provider, and you've gotta do, 2 minutes of CPR, so.
I get the antivia out so I can, make sure my compressions are good.
Make it so. Yeah. My phones are being off. Are you doing continuous, or you're doing 30 and 2?
Should be doing continuous for our protocol.
For our protocols? Well, for here, they're gonna want you to do, so give some breaths, like 30 and 2.
Okay.
And you can simulate your breaths.
I think I'm at 30.
Okay.
Yeah.
Breaths.
Breaths.
So we don't have a video.
Ventilate. Ventilate.
I'm pretty sure I'm at like 2 minutes here.
Yeah, you're at 2 minutes now, so
Ventilate.
you got, your AED showed up, I don't know how to use this thing.
Ventilate.
You don't know how to use this thing?
Nobody knows how to use it.
Wow, okay.
That means training is lacking.
We really,
Hook it to that.
okay.
Let's hook it to that. Let's use patches and connect it to our jump box. Patch placement, you can verbalize that.
I'm gonna go anterior and side.
Thank you.
And how about EFib?
This one will be the automatic.
Look at that. So am I done with CPR?
Are you? Have you shocked yet?
No. Analyze?
Analyzing now.
Yep.
Stand
Automatic.
clear.
Let me switch.
No, hold on, standing clear.
That is a point.
Shock advised.
Shock advised. Charge in. All clear, you're clear, I'm clear.
Stand clear.
Clear.
Shock,
Push shock button.
shock delivered, back on CPR.
And you're good, you're done.
Alright.
Start CPR.
They live or not?
I don't know if they live, but.
Somebody else's sheet. I'll give you any, Jim.
Oh, my sheet?
Come on, go team, go.
Alright, Caleb's up. Caleb's going.
Alright, come up, BSI, scene safe.
Yep.
Alrighty, I'm gonna look, listen, and feel for chest rise and fall and for a pulse.
You have nothing?
No pulse, I'm gonna start CPR. If you grab an AED, will you call 911? Do this at a rate of 30 to 2.
We're gonna do 2 minutes of that. So how many cycles do you think we'll get in?
Ventilate. Ventilate.
And we're one person, okay?
Oh, we are?
Yeah,
Okay.
we're one person CPR.
Take your breath back.
So Charlie, stop being so helpful. You take the ball and go home.
Ventilate.
And we don't have a bag bound mask, you're a layperson.
Oh.
Okay.
That's what I told him earlier.
He doesn't know
Who
neurogenic shock.
actually had one of the blow the mask,
The first time I ever did
little
it,
pocket mask.
Ventilate.
Oh, yeah.
Ventilate.
The plastic, hard
Yeah.
plastic. Yeah.
Still got it in my truck.
Do you really?
Yeah.
Wow.
You got one? Look at you, rescue Brandy.
Little one-way valve on there.
It's really gross.
Yeah. Yeah.
Ventilate.
Standard issue in the military.
This is your last set. We're at a minute 30.
We were supposed to carry them,
Oh, really?
and then they went to the one that you could fit in the belt pouch.
Yeah.
Carry
Carried
the
that for
roll-up
years.
one.
Like just the
Ventilate.
plastics,
It's like a
Yeah.
film AED.
Yeah, showed up.
Are we at 2 minutes?
Yeah.
Okay,
Big one
2
for
minutes,
those.
AED's here,
Okay.
so talk me through it.
I'm gonna put on the patches.
Yes,
It's gonna advise me whether a shocker
and
is
you,
needed or
and you
not.
turned it on?
Or, yeah,
You
it's gonna,
good?
it's gonna run through its whole thing.
Go ahead and make it,
Okay.
make it
So
happen.
turn on.
Yeah.
Patches are on, it's gonna have a rhythm. It's gonna say whether to,
so
there's a fit. It's up, or wait, sorry.
it's in a bib, so you have to, one, change
Oh, yeah, go to paddles.
Analyzing now.
There we go.
Stand clear.
Everyone clear?
Shock advised.
Shock's advised, it's gonna charge. I'm clear, you're clear, everybody's clear.
Stand clear. Push shock.
Shock, and then right back onto the chest.
Start CPR.
Perfect. So, this next time when somebody does, when we're pausing for the AED, somebody else jump on compressions and make sure you direct them to stop compressions. Okay. Alright, who's next?
I'll go. You wanna go, Jimmy? Go ahead.
You don't like being on that side.
Alright, you're here, you got a patient down,
You wanna show your face at the camera?
he wants to do
I'm a
CPR.
solid 5 out of 10.
Okay.
Okay, make sure, got BSI, make sure my scene is safe, patient's dry, no nitroglycerin patches. or
How do you
anything.
know? How would you know?
Well, you got no shirt,
Okay,
so,
so they have no.
yeah. So check patient responsiveness, hello, can you hear me?
They do not respond.
Okay, and I'm going to check the carotid pulse,
Yes, no pulse,
look, listen, and feel for breathing.
there's no breathing.
Okay, instruct a bystander to, call 911 and grab an AED.
Perfect.
Going to begin compressions.
Table's holding up.
I'm surprised.
Little Jimmy gets your muscles.
Oh, yeah.
Ventilate. Ventilate.
You gotta move faster between those. Hand Debbie said you should be moving faster. He does.
Yeah, I know. I'm working here.
Ventilate. Ventilate.
Not better.
Those are good blows.
Yeah, strong work. Strong work. I saw
Not for you.
adequate chest rise.
Ventilate. Ventilate.
Charlie's showing off the camera now.
I've got my back.
You only had a minute 15.
Ventilate. Ventilate.
You got a squeaky patient.
Yeah.
Ventilate. Ventilate.
I got this new fancy thing for you.
Wow, that's for me?
It's arrived.
I'm gonna have,
You got a minute 50.
no, okay.
I'll hop in for a shot.
Ventilate. Ventilate.
I'm gonna have bystander, continue compressions, going to grab, AED.
What? I had it set.
Gonna apply,
Ventilate.
gonna apply patches,
Ventilate.
right right side
Thanks,
chest,
that's the shot.
and,
Yeah.
axillary.
Yeah. I would love to.
Okay, stop compression, we're gonna analyze rhythm.
Analyzing now. Stand clear. Shock advised.
Okay, make sure everybody's clear. I'm clear, you're clear, we're all clear.
Stand clear. Push shock button.
Shocking, and back on.
You're good. Next.
Start CPR.
Oh, no. Next. Paper. Thank you, sir.
I did the Imperial March through metronome and it does check out.
Jimmy did his own examiner over here.
Did I?
Yeah. I'll fill that.
Trying to-
I'll let you trying to help.
He
He's
tested
proactive.
himself.
He tested himself. You know, when you've been doing it as long as Jimmy, I'll give him that.
It's not that long.
Jimmy, you and I are both approaching 30. Yeah.
It's true.
Years, not age. They're junior. Okay, continue. All right, here's your patient. Okay.
PSI seed save, walk up and I don't see any motion or anything, no signs of trauma. And, do a head tilt chilling.
Yes. Check for pulse. There's no pulse.
Yeah, I'm gonna start CPR. I found the problem, his arm's missing.
It's also got some holes on the
Hypo-
middle here.
Hypovolemic shock.
Well, I mean, that could be congenital, right?
I guess it could be.
You're breathing.
Ventilate.
Breathe. I'm not too short for this.
Yeah, Jimmy's up on his tippy toes right now.
Ventilate.
You're gonna put it down for workout, right?
Yep.
Okay, good. 2 minutes of cardio. Tell us when you grab an AED.
Grab an AED, someone, and dial 911.
It's coming.
You're in a minute.
Ventilate.
He's like,
Ventilate.
that's only a minute.
Ventilate.
Breathe, breathe.
Ventilate.
Good timing between ventilation.
Is
and
it
chest
AED
compression.
here? It's not.
What time are we at?
It just got delivered.
Okay.
Ventilate. Ventilate.
I'll check for a pulse. I'll turn on the AED. See, first thing coming down here.
I didn't hear it.
I'm not.
I have to change the lead, Jim.
Ventilate.
Up.
Check rhythm. Just the paddles. Just the paddles.
Is the paddle?
What was that though?
Yeah, that's what.
I was gonna last out.
Ventilate.
5th Street.
Ventilate.
I'm gonna pre-charge the monitor. Oh, analyze.
Analyzing now. Stand clear.
Stand clear.
Shock advised.
Everyone's clear.
Stand clear. Push shock button.
Everyone clear.
Start CPR.
You're good. You're good.
Okay.
Next. Jump in there.
280s, John Gifford. So if you have somebody who's unresponsive, but they're in VTAC, but they have a pulse, it's gonna tell you.
It's gonna shock.
It's gonna tell you to defibrillate.
We would be looking it up at the time.
No, if they're unconscious but have a pulse.
It's not, it won't be able to differentiate,
Yeah, that's what I thought.
so it's still been shot.
Yeah.
It'll probably is gonna be the best treatment. You're good?
BSI seems safe.
Yep.
I'm a level responsiveness, sir, can you hear me?
No response.
Nothing, head tilt, chin lift, look, listen, feel, pulse.
You have no
carotid
pulse,
artery.
no breathing, do you want help?
Yes, you call 911, use the AED.
Perfect.
One of two, you've been added to the alarm on company 5, which will now be EMS communication, 4045, overlaid, pediatric, solid treatment, personally AC, one patient with a head injury, another patient with an arm injury, shelter back.
The arm hit the head?
Yeah.
Interesting.
It might,
Ventilate.
it might end up, yeah.
Ventilate.
It might end up being, we might end up going to that one.
Where's the, we're going that one?
They're gonna, if they assign us, it'll be us.
Yeah.
If they assign it, I mean, it'll be us.
You'll finish this.
Ventilate. Ventilate.
You're at a minute and a half.
Ventilate. Ventilate.
When you do additional ambulance, figure out what you got.
Number 1.
Look up the
Yes,
AED.
mechanic, we'll take it.
Yeah.
3 hour compressions.
Ventilate.
ADO, turn on, attach pads.
Hey, you can put, company 7 back to where it
Alright, am I clear to analyze everything?
Analyzing now. Stand clear.
Ventilate. Ventilate.
Shock
You've
advised.
been added to the alarm. 4045, Southwest Slipper Lane.
Stand clear. Push shock button.
Everybody clear? Charge?
That's pretty close.
One
Where was
head injury,
was way down south.
one
on the
injury,
CPR.
We're going right past one.
Start CPR.
They already had it into the system, so.
Take it.
Yeah.
Did you deliver your
Yeah.
shot?
Yeah.
Back up. You gotta need 3 to do the.
Yeah. You're good, shut that down. We're good on that. And then we're just hooking up non-breathers.
Ventilate.
Alright. BSI scene safe?
Needs of the department outweigh training. It's important.
BSI scene safe. Sir, what do you need?
Take it on.
Oh, yeah.
And this is your airway kit.
Oh, is it?
And our,
Yeah, we got it.
There you go.
airway bag too.
I'll grab a, thank you.
Did you go ahead and tell them?
I will.
Should be an airway kit in here.
I'll see it.
Slipper Command, 127. Yeah, Jetted. I copy med 7, inside med 3 on the Clipper alarm at 1228.
Alright.
That's a crusty one, but it'll work.
Just a bit of a tinge to it.
Yep, just slightly used.
So BSI scene safe.
Yep.
Sir, go through my assessments,
Got your equipment.
the
Yep.
equipment, looking at, the patient, seeing what if they need medical or oxygen, and they do. Make sure my tank is turned on.
Yep.
Hook up the tubing.
Assemble the regulator to the oxygen tank. It better already be on.
Oh, yes, it was
I know,
on.
but
Oh,
it was already
okay.
assembled.
It was a little loose though. I didn't check
Yeah.
my, connection.
That's what happens when you use the
All
training.
right, sir, I'm gonna
training
give you
equipment.
this oxygen. It's gonna feel a little tight to your face, okay? But it's gonna help you breathe.
Clipper Command.
And they had you pre-fill, correct?
Sure.
Does that actually have oxygen in that tank?
Correct. there's no oxygen.
Okay, so we'll
You mean
verbalize
zero
pre-filling,
green,
yep.
till 29?
So I'm at 15 liters per minute.
Okay. Any leaks in your tank?
No leaks in my tank.
Perfect.
My mask has a good seal around, except for that isn't there for some reason.
All right.
There we go.
Perfect.
Reassess
You're good.
after a treatment.
Right on.
Same thing. Give your sheet.
You going?
Yeah, I am. Okay. BSI, scene safe.
Perfect.
Alrighty. I've seen that my patient needs oxygen, going to
Yes.
get everything ready over here. I'm gonna hook the regulator. I mean, if it wasn't already hooked up, I was gonna hook the regulator to the oxygen tank, crack it, make sure there's no leaks, anything, hook up the non-rebreather, pre-fill the bag by holding the flange.
Perfect.
Going to fit it over my patient. Let him know that this might be a little uncomfortable, but he's gonna need that oxygen. Tighten it down to his face to fit snugly. Reassess my patient, reassess the bottle, make sure there's no leaks or any air hissing or anything, and then
Perfect.
turn it. If I didn't already verbalize, we're gonna do at least 10, but just 15 liters.
15 is perfect.
So.
Perfect.
And that's it.
That's it. Continue to assess and monitor your patient.
Yes.
For the adequacy of your
Treatment.
There you go.
All right, Jimmy.
Okay. Did all the helmets used to have this blue? Gotcha.
That's just a custom thing.
Gotcha.
Whenever you're ready, Jim.
Scene safe, BSI.
Yes.
Then get ABCs and check the patient's breathing and pulse.
They're breathing, but they're labored.
Whatever.
O2 therapy.
And we're gonna use our oxygen bottle here. Check for leaks. We're gonna make sure it's full. And
It's got plenty of oxygen. There are no leaks. Connected it to the correct spot on the regulator. Not a high pressure port, which is hard to do.
yeah, come off really quickly.
You can do it once.
Shoot across.
Exactly.
He's pre-filling.
Yep, he's pre-filling. Yep, it's full. Kayla, thank you for not manually inflating that.
Okay, Dale.
Properly placed on the airway, and then
This is gonna be uncomfortable. It'll help you breathe.
Please tell me if I perform, if you respond, please tell the police department.
Check those you said, listen to long sounds.
and we're done.
Okay.
Thank you. Let me check my time, make sure I'm good.
Should be.
Oh, I'm sure you are.
I was like a minute, hour and a half on our break.
No.
I'm at 2 hours and 3 minutes.
Well, I thought.
Oh, we did start a little after 10 because of the game.
Oh, that's right.
Oh yeah, we were like 10, 15, 10, 20.
I was thinking.
All right, wave bye.
10 originally.
All right, why won't it stop recording?
Oh, it works.
It doesn't want to.